I have not come to a decision yet. Y'all know how I do. I have to take at least a week to look over those and have an internal debate before I decide. Usually I have to have someone be a tiebreaker for me because I always get stuck on at least two of them. But I will let y'all know. So we'll be wrapping up this chapter this week. And when is y'all's first test?
Monday?
Next Monday, if I'm not mistaken. Next Monday. Next Monday, yes. So don't forget also what else is due on that day. The workbook pages, yes. Easy 100 or easy 0. Please get those to me. All right, so we'll wrap up this chapter today and Wednesday, and of course we'll do a review on Friday to make sure you're prepared on what info to expect. And let's go ahead and move on. Just a little bit of wrap-up info before we get into positioning. By the way, how are you feeling about the positioning overall in lab? You've all had lab at this point. How's the positioning feel to you overall for this chapter? Is it the oblique ribs are kind of dodgy? Yeah. We're going to go over some techniques for those. I think we'll get to those on Wednesday in this class, and I'll show you all some little tips and tricks of how to determine which ones to do, because that is very important as a tech to know exactly what ribs you're imaging, and also just a way to not get as confused on those obliques, because they do tend to be a confusing part of being a tech. And as I told you all, there are techs that have been doing this for 50 years that still can't do ribs properly. They do the wrong side, the wrong angle, the wrong oblique. It can cause all kinds of issues when the radiologist is able to actually notice that. And they, depending on your radiologist, they will notice that and send them back to you and say, hey, what are you doing? This is the wrong side. And you're trying to think like, well, why? I did an oblique. Well, you didn't image the correct side using the correct oblique based on the patient's side of pain, like anterior right, posterior left. And it's going to change depending on what we're trying to look at. All right, so some special patient considerations, guys. Of course, pediatrics. The biggest thing we deal with pediatrics, of course, is motion and their safety and limiting that radiation exposure, because their cells are a lot more susceptible to radiation damage than adults. But the big thing is going to be motion. And the reason I put this in here specifically is because you're going to do a lot of ribs on pediatrics if you ever work in a pediatric facility. Why? Because as I was telling y'all last week, that's usually what you're always going to do when they're looking for abuse cases. And we do get a lot of those in children's hospitals. So holding them still is going to be vital. They're going to be squirming around. You can't tell a 3-month-old to lay there and be still. It's not going to happen. They're just going to goo goo gaga and scream in your face. So you got to get a team to hold that child down, and do not be deceived. Children can be deceptively strong. And I've told y'all this before, they can Hulk out on you. I mean, I've had 2- and 3-year-olds lift us almost off the table sometimes, because when that adrenaline spikes, you're capable of superhuman stuff sometimes. So you always need a good, competent team holding those children down so that you don't repeat the x-rays, because we're always looking at that exposure as well. Geriatrics, they often come in with a lot of rib injuries as well because of falls. A lot of our elderly failures, I'm sure you've had them have falls before where they hurt their hips, but they also hurt their ribs quite often. Primary concern is that sensory loss associated with aging and those falls. One thing we want to be concerned with as well is we don't want them to fall during the exam and further injure themselves, because we will be liable for that, because we'll fall under neglect if we're not watching those geriatric patients very carefully. Obese patients can be very difficult for ribs. Find those bony landmarks. So one tip is to always go by that jugular notch and xiphoid process. The good thing about all the positioning in this chapter is almost every position, you can rely on that jugular notch and xiphoid process to some extent to find that centering properly, especially if you're having trouble locating the area on a more obese patient. And of course, trauma patients, we always got to think outside the box with these. They're usually have to be done recumbent, which means what? Laying down, correct. So that's going to be your cross tables and your alternative exams that we're going to talk about as well. But if they can stand, that's always going to be the best mode of action. Standing is always the optimized position. We never want to lay them down if we can help it.
Under the obese patients, it says the xiphoid process. Can you copy that?
You can. You can palpate it on yourself right now.
It's just such a strange place.
It is, and it's probably not the comfortable place to palpate, but if you're having trouble locating your centering, that's always an option as well. You know, jugular notch is pretty easy to find with everybody, no matter their size. That's a good one to always use. But that xiphoid is there, and that's going to be really important for our sternum x-rays, and we'll show you in a second why that's so important. Because one of our centering points is going to be halfway between jug notch and that xiphoid. So one thing I always try to instruct people to do in lab is to have the patients do this. point to the top and bottom of your sternum, just go in the middle. Little cheat trick there.
So if they're able
Cheat
to
code.
stand and they're a trauma patient, we can do it standing?
Yes, but that's something you're gonna assess as a tech, and
Yeah.
you always gotta take into consideration patient comfort. Because some patients will be in a trauma situation, they'll say, oh, I can stand up. As soon as they stand up, they fall flat on their face. I mean, they've been drugged up with painkillers or other stuff. You have to be very careful and keep that in consideration. Yes?
For the PA sternum, you know how you were doing the jiggler notch and the xiphoid process? When we're doing it live, like, it's pretty much T7.
It varies though. You gotta be careful because sternums vary in size. Some people have a very long sternum, some have a short sternum. So yes, on average, T7 is a pretty good start point. But for me, if you're going for that optimization factor, have the patient do this to make sure you're centered dead center on that sternum. It does vary. So we have a very long torso, so that sternum's gonna be longer. So we have a very short torso, it's gonna be tiny. So do be careful with that. Average size, yes. All right, so rib fractures, when do these occur? Most common, yeah.
Is it
Yep.
sometimes like when they're thicker, does the jugular notch move? Like is it higher?
Jugular notch doesn't really move.
No, like
per se.
you know, like when they're chunkier, like you have to go up.
I mean, it does depend, it varies.
Okay.
Some people's chests are like more barrel chested, some people have like a higher chest, lower chest. It does vary. So I said you gotta be careful with that. If you're talking like an average sized person, yes, T7 is a good start point, but for me, I'm like better safe than sorry. I'm gonna tell them to do this just to optimize that center. That's me personally.
And then center of the sternum, sir.
Correct, in between. And we'll get to that in just a second. That's gonna be our first position we talk about. All right, so rib fractures, most commonly a result of our trauma cases, may also be what we call a secondary injury. It may cause what we call a secondary injury, rather, to the lungs or cardiac structures. Why? Because when a rib becomes detached or fractured, what can it do? It can move anterior or posterior. It can cause punctures to those vital organs. So that would be what we call a secondary injury, and that can lead to pneumothorax and cardiac contusions. What's pneumothorax, by the way? Air in the thoracic cavity. And what's a cardiac contusion? Contusion on the heart. It's a bruise on the heart, correct. So as you can imagine, it'd be a very dangerous situation. It could actually puncture the heart itself and even cause death. Yes. Sternum, also a result of our traumas, and also, as we saw with some of those different pathologies last week, congenital anomalies. Congenital anomalies. Those are called congenital anomalies. They're genetic deformity. And then metastases, that's going to be the spread of malignant neoplasms such as cancers. And then an osteomyelitis, that's going to be an infection of bone and bone marrow that can also occur in those bony thorax areas. What do we call our clinical indications and more common pathologies? Congenital anomaly is like a genetic disease, a genetic deformity. Congenital, basically, congen is another way of saying genetic. All right, well, no, this is not the end of the lecture. It's just the end of that section. So we're gonna move on now to our positioning. Positioning, so this is gonna be the radiographic positioning in chapter 10, bony thorax. On our journey here. So, as usual guys, this should look very familiar. Not much has changed on our prep and our procedural guidelines. We're gonna talk a little bit about our patient prep, our general patient positions, there are quite a few variances on the bony thorax. Of course, as I said, when we talk about these variances of position, we're always gonna assume that we're always gonna state that the upright position will always be your optimized way of doing all of these, with the exception being SC joints. laying down is the best way to do those. But other than that, you always want to stand the patient up if possible. Not to say you can't do it laying down, but it's just better standing. IR collimation size is going to vary quite a bit amongst these positions. I want you to write these down and put a star by them, because that's an easy thing to miss on the test, because we can always get stuck on that 8x10, 14x17 mentality. But you're going to see a lot of varying size depending on what body part we're looking at. And we're dealing with some small body parts in this chapter. SID is going to vary as well, guys. So there's that sneaky REO sternum position, of which we're going to use that 30-inch SID, which is a very uncommon SID. In fact, this is the first year, this is the new edition of Merrill's. This is the first time they've ever used this SID, at least to my memory. They just changed that with your editions. They're considering that a more optimized technique, and I'll show you why on the slide. But in the past, we always did it at 40. But now they're saying 30 is the better option. So that's what we're going to go with. That's what the registry will reflect as well. ID markers. All right, I hope we remember this, guys. After being harping for 2 semesters, what's the golden rule on ID markers?
No digital.
No digital. No digital. And I swear on my grandmother and grandfather's grave, if y'all miss out on your registry, I'm going to come after you. Don't miss that question. Radiation protection as well, and then our patient instructions will be very vital, because there's going to be a lot of different breathing techniques in this chapter as well. So while we have less positions and less anatomy overall, the complexity is going to change, because every position is going to have different variances on those breathing techniques and patient instructions. So make note of that as you're writing your notes. Don't assume they all are done the same way as a lot of positions in the past have been. Because we're dealing with the thorax, once again, those breathing techniques are going to be very vital. They're going to vary depending on the part we're looking at. All right, patient prep. So for bony thorax, of course, we're going to require the removal of all those artifacts from the anatomy of interest. Big ones, of course, those necklaces, and I'm sure y'all have dealt with that by now, right? Have y'all taken a chest x-ray with a necklace yet? Anybody? You can admit it, I did it all the time. It's nothing to be ashamed of. You can say, do you have any jewelry on? They say no. You take your x-ray and there's a cross or a star or something in the chest, right? Y'all been there? Happens all the time. But, you know, make sure, you know, don't tell them to show you. Like, let me see your chest so I can make sure the necklace is there. You have to, you know, ask them nicely, and then hopefully they'll get the idea and remove it, but a lot of times they don't. Aside from that, clothing artifacts, of course, buttons, guys. Do not be deceived. Buttons will show up on your x-rays. You may think they are radiolucent, but they are not. Not all buttons are created equally. Also, a lot of the elastic on shirts, even little tags on shirts will show up on x-rays. So to be safe, just like a chest x-ray, guys, you want them to remove everything from the waist up, including their bra, to get that out of the x-ray field, because it will likely show up on the x-ray, especially our digital machines. You don't want a big Nike sign on your chest x-ray or your rib x-ray. I've had that happen before. Nike, big Nike logo on my chest x-ray. Someone's like, oh, I think I didn't notice that he had a shirt on, he had a gown on, and he had a Nike shirt. There was the Nike symbol.
I had a patient with this pierced.
Oh, that was pierced? That's an interesting piercing spot. Like at the jugular notch?
Yeah. It was a little
Is that something new?
They put
No,
it
it's
here and
old.
then in the middle right here.
I'm not familiar with that
She only
piercing
had
spot.
one, and we saw it, and we were like, what is that? She was, oh, I just got it pierced like a month ago, so she went to check it out.
That must be new, because piercings were all a thing when I was younger. I mean, in the 90s, everyone had piercings, but I almost got a piercing.
Which one? This
Where?
one? This one on your eyebrow? It was that one, huh?
I want to get a piercing right here.
I can see that.
Yeah, but I didn't. No, I didn't.
You didn't want the septum? The bull nose?
No, like, reminds me of a horse, you know, like, whatever.
It's a bull.
A bull, yeah. Whatever. Whatever it's called. But no, I chickened out the last minute.
That's funny. I always said if my nose closed, I would never do it yesterday.
I didn't mind it, and I was like, no, I'm not gonna look at it.
But also, guys, be careful, because my arch nemesis on all these thorax, chest x-rays, really any x-ray done with the torso, I've mentioned it before, my arch nemesis, and I swear those nurses always screw me over with this. You know what I'm talking about?
Lead.
The lead stickers, yes.
Oh, the.
Always ask your patient if they leave any stickers, because they're not going to know what leads are, but they know what stickers are. Do they leave any stickers on your chest? Can you peel those off? Oh, but it hurts. Please still take those off. Please take those stickers off.
The older people usually get slashed, right?
Oh, that happened to me all the time, yeah.
I was like, you have any stickers?
Grandma and grandpa will always take their
Yeah.
clothes off, yeah.
Do I?
But do be careful, speaking of elderly, because we talked about geriatrics, guys, with those stickers, often you're going to have to help them take those off. Please don't rip those off, because you might rip a whole chunk of their skin off with it. That does happen. Like my wife, for example, she's very allergic to adhesive. So anytime she has lead sticker, she like breaks out in hives. So you gotta be very careful with that stuff, and especially your elderly patients, their skin's very frail. You might rip a whole chunk of their skin off, and I have done that before.
Yeah.
I'm saying that from experience. It's not as bad as it sounds.
There was one guy, he had like his chest was so hairy, Mr. Donahue was so hairy. And I was trying to help him take the stickers off because he was going too slow. And so I started helping him and I felt so bad because like I know it hurt. It was very hairy.
Yeah.
Should call Miss
Hairy
Shepherd.
chest, you're kinda out of luck on hairy chest. Someone's gonna like rip it like a band-aid. Like,
Yeah, Miss Shepherd would have been on that.
Oh, you need help?
I'm still gonna, okay, yeah, don't let me forget, I still gotta tell that story. It's a long story. It'll take about 30 minutes to tell that story, just don't let me forget it.
Study hall.
Study hall? Okay. All right, and of course, guys, please secure all patient possessions in a designated manner, location. Make sure they know that you're not stealing their stuff. You get some crazy person, they're gonna threaten you with stealing their wallet and their phone. That's happened to me as well. Just make sure it's a secure location and know where you left it. Don't ever have them leave their stuff in the bathroom, by the way. It's a common mistake. That can lead to a very uncomfortable situation if they're accusing you of things. All right, so ambulatory patients, of course, they're going to be our upright and recumbent patients. Ambulatory stands for what? A little review here. Walkie-talkies. Non-ambulatory is going to be what? Non-walkie-talkie, right? We're going to alter their position to maximize patient comfort. That's going to be like our trauma cases, of which we need to do alternative positions. Trauma patients in particular. Make sure you examine the position in which they arrive, and then you're going to use those critical thinking skills to achieve that optimized view as well. And one of the hardest ones to obtain would be those sternum x-rays, of which we can do an alternative method, especially if they're on a backboard on their back. Because what I say, we always do the REOs. That's the only thing we do for sternum. Well, there is an alternative to an REO that's synonymous, and that's the LPO. Now, is that going to be the best view of a sternum? No, but we'll still get a pretty good one because it's going to be massively magnified because of the OID. But there's always still a way to obtain an image. And the reason I always have to bring this up, guys, I know y'all work with some of these texts that say it's good enough. It's never good enough. You can always do better. You can always think outside the box and optimize those images to get you a quality image to that radiologist. So I always say, remember your name's on this stuff, and your reputation precedes you. You don't want to send trash. I hate sending trash. I'm not going to send trash. I'm going to send the best thing I can obtain. I'm not going to be one of those texts that has a bad reputation. Y'all aren't either. Y'all going to be the best. That's my goal, at least. Y'all don't seem very enthused about it.
It's Monday. You know what it is.
I just want you to remove from your vocabulary, that's good enough. I hate that phrase. I don't even let my kids say that. No.
Your kids kind of like show interest in what you
Yeah, my oldest daughter wants to be a teacher, like her daddy, as she says. But she wants to teach elementary school.
do. Bad.
As of right now.
As a
Kids
girl.
are bad.
Benjamin, he wants to, he keeps going all over the place. He wants to be an astronaut, he wants to
I don't know
be
why I had that in my
a
head.
game designer, he wants to be a scientist. He's all
Whatever's
that's-
cool, right?
Huh?
Whatever's cool.
Whatever's cool at the moment. And then Lily, she just wants to be like a fashion designer, which fits her perfectly.
I'm gonna use daddy's credit card.
Yeah, Daddy's credit cards are gonna be in the safe. She's older. She already begs me for a dress every time we go everywhere.
Yeah.
I get a new dress, Daddy. I just bought you a new dress, Lily. But this one's so pretty.
And you buy it.
And she like bats her eyelashes at me and is a little flirty.
He's
thing.
like, put it in the basket.
Yeah, yeah. She has this power over me. She has this. She can always. I don't know. My other two can't convince me, but she can always convince me. I don't know how she does it. All right. Anyway, let's back on track. IR collimation size. Of course, guys, this has not changed, especially with last semester with the small extremities. We're going to always use the smallest IR that will best demonstrate the anatomy. That's going to optimize and give us the best quality images. For sternums, we're always going to use no larger than a 10 by 12 that needs to be lengthwise. Why does it need to be lengthwise? Because the sternum is long, correct. Always think about the part and its shape. Is it long or is it wide? If you're having trouble about that crosswise versus lengthwise. SC joints, still going to be 10 by 12, also lengthwise. But keep in mind, even though we're listing 10 by 12, 10 by 12, we're not gonna leave that collimation open at 10 by 12, are we? No, we're gonna collimate even further, and I'll give you those exact dimensions as we get to each position, because we want to optimize and make those images nice and clear, because they're very small body parts. Now ribs, very similar to a chest x-ray. It basically is a fancy chest x-ray. 14 by 17 cassettes, that can be lengthwise or crosswise, depending on the patient's size. And most of your males, you're gonna opt for the crosswise. Males have broader shoulders. Most of your females will always be lengthwise, but you've got to use your own judgment based on that body habitus and how they arrive. And of course, collimates that field size to the anatomy of interest. Collimation is your friend. It is not, I know your techs like to open it up. I say close it up. Now I know you have to do what they say, but please, when you become a tech, don't open it. Just, I'm gonna give myself an anxiety attack here. I hate when techs do that. That is so sloppy and such bad. I'll get your question in a second. I gotta get through my rant here. In a second. I hate when techs leave it wide open. That's just a sloppy practice. It's a lack of confidence, and you're doing the patient harm. You're overexposing them, and once again, you're making yourself look bad. You turn an X-ray of a little finger and you open it wide open. I swear that radiologist is laughing at you. Like, where'd this person go to school? Like, where? If you go to Harrisdale, if you do that, don't say you're from Harrisdale. Say you're from like HCC or St. James. That's the kind of junk they do in those schools.
So even though they make it wide, they crop it on you.
Oh, and
They
then
always
the
crop
cross,
it.
yeah.
That's sloppy too. See, if you collimated correctly the first time, you wouldn't have to crop it.
Ooh.
See, they try to make it look like they collimated, and let me tell you, they think they're crafty, but you can always tell when someone's cropped something. When you
Yeah,
go into
'cause it had the
packs,
white-
you can tell it's been cropped, and you can uncrop it and see you can see all the alterations they did. I used to QC films all the time. You can always do a paper trail and all that stuff. People think they're sneaky. There's a paper trail on everything. You cannot hide anything. I swear to you. I used to call people out all the time that was doing that charge tech job. Oh, I'm sorry, Emily. What's your question?
So for the sternoclavicular, okay, so for sternoclavicular articulation, I thought Ms. Bonilla said it was 6 by 8.
The collimation is, but you're going to start with the 10 by 12 cassette.
Oh.
We're not to the collimation yet. Good point. She is correct. It is 6 by 8. All right, so SID, guys, be careful. This is where people always miss this question every year. Watch out for these SIDs. For your PA oblique sternum, this is an update in the newest edition of Merrill's, thus this will be reflected on your registry. Although you will see text still doing it 40, and most people will tell you 40, the new optimized SID is 30 inches. Why? That's going to assist us in blurring the ribs further. Assist in blurring those posterior ribs further, thus optimizing that sternum image. Now when you go to the lateral sternum, you're going to bring that SID up. That's going to be a 72-inch SID. Why? Because of the OID. We're going to reduce the magnification and distortion, which is caused by that natural OID of our chest. So 30 inches on that PA oblique, REO specifically, that's the only PA oblique we do. Lateral, 72 inches to reduce that magnification and distortion. I'm just going to tell you right now on your test, I will have 30 and 40 on there as answer choices.
So you want us to do 30?
I want you to pick 30 because that's the optimized SID.
You should use metric system for bonus points.
What's that?
Metric system for bonus points.
76.2 centimeters.
No.
Thankfully, they don't ask that. Thankfully, they always stick with inches on the registries. That'd be evil to ask questions like that. Question?
So for the 30 inches, you won't be able to lock it, right? Like,
Correct. It depends on the tube as well. It might float on you. Of course, in cases where you're just by yourself, it's not gonna stop floating. You probably just go ahead and do it at 40. But if you have a tube that's gonna sit there in place, 30 is gonna be that optimized SID that you wanna go with. Or if you have someone to hold it for you.
Is it gonna sit, or, cause I know sometimes it'll say like, it'll have the hole, the red light.
It won't let you shoot.
Yeah.
Once again, that's gonna vary per room. Yeah,
So if we do get that light, then we just do it at 40?
yeah, because I mean, you can't, well, I say that there is a way to work around that. You can put it on manual and
Not for PSP.
all that, yeah.
and then measure.
Yeah. So like I said, this is brand new, so we're not gonna see many people doing this yet. They just changed this year. That is what they're saying is the best way to do it now. Now ribs, that's gonna vary by department. You're gonna see some techs do it at 40. You're gonna see others do it at 72. And that's just gonna vary with that distortion and spatial resolution. Me personally, I've always learned to do it at 40. That's what I'm gonna stick with. Now, as far as your registry goes, they would not put both of those numbers, just one or the other, but both would be correct. Does that make sense? They won't put both those numbers, but one or the other, and both are considered correct. I will do the same thing. I won't put both of those. I'll put one or the other, but both are correct. It varies per department. It's basically a personal preference. Now, I would say, even though I learned to do it at 40, if you're scared that you're not going to get all the ribs in one X-ray, like you feel like you have someone with a really long chest, do it at 72. You have a better chance to get them all on there. Critical thinking, once again. 40 will look better, but 72 will get them all guaranteed. See the trade-off there? All right, of course, guys, we always use digital annotation, right? Because our techs do it all the time. No, we're of course going to always include our right and left. There's going to be physical anatomic markers. We never use digital for any reason, any circumstance, whatever that word is, circumstance. Even if our techs are pressuring us to do so, and they always do it on the portables, right? Especially around pediatrics. If they say, oh, you can't put a marker near a baby, it's not true though, because you can. They used to do it all the time. We don't do it because we're in a hurry. That's not true. They're just being lazy. We always put our anatomical markers, period.
It's hard for me.
Get used to it. It is difficult, but it's rewarding. All right, when it says other required ID markers must be in the final image, that's going to vary per department as well. Sometimes you have different markers that are going to specify, like cross table, where the patient's standing, it says erect, recumbent. If those are in your department, you want to go ahead and use those as well. It's just going to make your image look better, but they're not required. The ones that are required are the rights and lefts, at the very least. That's been a rough weekend. You all look miserable today. Everyone's like,
Have had an extra day of the weekend.
that 3-day weekend was too good last weekend. Huh?
Is this the semester where you're like,
You're almost halfway done, though. That's a good feeling, right?
it doesn't feel like
It goes fast. All right, guys, all our positions in this chapter, we are going to use close collimation and gonad shielding, and that still has not changed per state regulations. And I keep telling y'all that's probably going to change soon, but for you guys, you are grandfathered into still using shields. And I want you to keep that in mind, because if you're a person like me, you like to read research articles and the latest and greatest, I'm sure none of you are like me. No one's that nerdy.
The SRT things?
You'll also see TSRT presentations concerning this. As of now, you are grandfathered and still using shielding, despite what you might hear with the latest trends. Even though it's trending with them going away with shielding, you're still using shielding until further notice. Okay? Let's keep that in mind. All right, patient instructions. Of course, we're going to explain and demonstrate positions whenever possible to help our patients, especially our non-English speaking patients. We're going to give them a little acting skills, make sure they know exactly what to do, use those hand motions, use those signals. These respiration instructions, as you're going to see, guys, they're going to change per position. They're going to be essential for imaging bony thorax. If we do not use the correct breathing instructions, those images will not look good. It's going to be very important, especially when we're going from upper ribs to lower ribs. It's going to change. It's going to change between areosternum and lateral sternum. It's also going to change with SC joints. Every position has their own unique breathing instructions. So I want you to be careful, keep that in mind, and write those down. Make sure you differentiate between them. Give those clear explanations to reduce the need to repeat studies, because if you're an ethical tech, you'll be able to notice the difference if you do the wrong breathing instructions, and you should repeat that before you send that over to the radiologist. So make sure you are being specific with those instructions and doing the correct ones per exam. Has anyone seen someone do a breathing technique in the clinic yet? Where they set the breathing technique and it's that long exposure while they're breathing? They're kind of difficult to do, but man, do they give you pretty images when you do them right. A lot of techs won't do it because they feel intimidated. A lot of techs don't like to use manual techniques. They like to AEC everything. Because y'all never AEC, right? Y'all never do the AEC. Y'all are better than that, right? I am assuming most of you use AEC, but let me tell you, there is such a difference whenever you learn to master manual techniques versus AEC. And I would have never appreciated that had I not worked at TCH, because you're not allowed to use AEC at Texas Children's. You have to do manual techniques. I talked about getting some pretty pictures when you master it. Makes a big difference. Probably AEC.
But it's hard because then you have to just like
No
work
one to do
like,
it.
and they're like, well, that's something I can't teach, that's something that I learned, you know. So-
Sure, 'cause I
I.e. they don't know.
Yeah, they don't know.
It's a lost art. It really is.
Would
Yeah.
you recommend that we go by the guidelines that they have posted usually?
What I would recommend you do, if you're gonna be a person that wants to use manual techniques, is wait until you find what facility you'll be working at, because it's gonna change per equipment, per facility. No two machines are the same. If you decide you wanna be a manual technique person, start learning on that place you're working, and then you'll be able to perfect the art of it. And then when you go somewhere else, you'll be able to like figure it out. It's hard to explain. Once you learn how to do it, you can go anywhere and just figure it out. You can do the calculations in your head and the math in your head. You're like, boom, you know what to do.
Okay.
You can look at somebody, know the technique, like you're 120 at 8.
For chess? Okay.
It'll come to you though. All right, guys, let's start with our sternum positions. We're gonna start with the 2 sternum positions. We have the PA oblique and the lateral, only 2, but there are some little variances we have to talk about on both of these. Now, for PA oblique, once again, when we're saying PA oblique, there is only one PA oblique that we do. Please be careful, because people still miss this on their registry. RAO only for PA oblique. We can do an AP oblique, but only when it's a what? Trauma patients. Otherwise, we are not going to do that position. That is not an optimized position, but it's an alternative when the patient cannot stand and they're flat on their back. So REO only, and you can guarantee on your test, and we'll have all 4 of those positions there. What is the best position for an oblique sternum? We'll have REO, LEO, LPO, RPO. You know, I might even make it a multi-point question. Select all positions that are.
That's evil.
But I want y'all to get that. It's a very important concept. That's a registry question right there. I've been using that one a lot. REO is always the best position that we're going to perform, the only position, unless the word trauma is in that question. Then it would be LPO. For lateral, we have the choice of upright or recumbent. Which one do you think is the better one?
Upright.
Why?
So they can poke out their chest and we can see the sternum more.
That is part of it. It's a little easier to puff the chest out and get that sternum separated. That's probably the best reason, because you imagine they're laying on their back, you're doing cross table, the chest is going to naturally be what? Relaxed. So that sternum's going to be superimposed over the tissues that we want to avoid. You can, but it's not going to help very much. And then, you know, if they're laying down in a lot of pain, are they going to want you shoving a pillow under them? Probably not. Maybe they're like in a neck brace and bones jutting out all over the place. Blood.
I've never had that happen.
These coffee's on point today. I'm doing better than that. I'm drinking a lot less. Y'all be so proud of me. I'm at least proud of me. No, I'm just trying to drink less because I'm drinking too much. I've heard it's good for Alzheimer's. It's good for your cardiac system as well, apparently.
Yeah.
It's good for my sanity.
It's a stimulant.
It's very good for sanity.
But just pure, right? Just pure. Like black
Right.
coffee.
Oh yeah, I'm still off of sugar. I've been feeling so good since I got off of sugar. I've been feeling optimized. Use that word, optimized. I have optimal quality in my mind right now.
Donahue, it's only been 3 weeks of 2023.
I'm feeling good for 2023 so far. I'm feeling really good. I was feeling bad at the beginning of the year, but I'm feeling good now.
Did you, that last week was, I'm sorry.
I was rough. It's y'all's fault.
There you go.
I gotta blame somebody. All right, guys, so what I say about the SID, once again, the optimized SID, big star guy, is not 40 anymore, but it's 30. Now, that does not mean you cannot do 40. You still can, but we're talking about the best answer now moving forward. It's going to be 30, and the reason is to blur out the posterior ribs better. The 30-inch SID will blur them out further. This can be done prone or upright. I don't know why you would ever do it prone if they can stand. To me, you're just sabotaging yourself if you do it prone. That's going to be a very slight oblique, by the way. How many of y'all accidentally did 45 degrees last week?
Me.
It's very easy to do because you get stuck on that 45. 15 to 20s is a very slight oblique, guys. You're barely turning them. Barely turning them. So ensure that left shoulder and hip are rotated equal amounts, because you can do this, guys. People can turn their shoulder, not turn their waist. You want to turn the whole body. Make sure it's in the same plane, otherwise it's going to look wonky on you. It's not going to look very good.
You said that it blurs out the
Posterior ribs. Now, what I do, guys, for my REO sternum, once again, I'm all about optimizing that picture and giving myself the best quality image. While we can use the T7 method, excuse me, not every sternum is created the same. They're different lengths, different sizes. So what I always do with my patients, and you can do this in lab, your choice, I have them point to their jugular notch, and don't say jugular notch, they don't know what that is. Help them point to the jugular notch, say put a finger here, and put a finger down here at the bottom of your breastbone. We can all do that. Have the patient do that, and then you can center in the middle of the 2 points. That will put it exactly where you need to be. What I'll do is I'll have them be in an AP first. As I put you back against the board, I'll find my centering and my collimation, by the way. Find your collimation. You need tight collimation. Now, at that point, I don't have to touch my tube anymore because I know I'm centered. Now I just move my patient in position, REO, and then slightly towards the elevated side. And I know the collimation is perfect. I know the centering is perfect. I just got position at that point. And I know I'm not going to miss it. Because you notice how that light, kind of like, especially if they're really close to it, the light changes sizes and it can throw you off. For me, when I was a student, having that AP first was the easiest way to make sure I'm centered correctly. Don't have to do that, that's just my personal recommendation. Also, keep in mind, when you're centered on that AP and then you put them in an REO, you're still centered for the lateral. You just got to put them in the lateral position and pull your tube back, and then just adjust your collimation. Make sense?
yeah.
That's just my personal recommendation for that. Little cheat code.
That guy in the picture was so.
Yeah, he looks really miserable.
Why is he wearing that?
No, he was sleepy, I don't know. He started taking pictures all day.
I don't like
Yeah,
that 'cause
he's
they
in a lot of
look
the pictures.
like a lot of them are
This guy's been in the picture since I was in school. Like, this is the same guy I learned off of in school
He
back
getting
in
paid pretty good.
2006, 2007, 2008.
The royalties be hit.
Yeah, he getting paid good.
Now also you can use the, put the top of your eye 1.5 inches above the jugular notch. If you don't want to use the method I was talking about, it's another way to make sure you're centered correctly. But for me personally, once again, jugular notch to zygote process, you're gonna get it every single time. Easiest way to do that. Make sure that you're centered correctly. All right, so even though most of us, including the text we work with, are just gonna have the patient hold their breath at expiration, which they shouldn't be doing. They should just have them hold their breath. It should be at expiration. The optimized breathing technique, guys, write this down with a star on it because it's gonna be on your test, is using a breathing technique to blur out the lungs further. That's a manual technique where we balance the KVP, the mass, and the time, or MA in the seconds, rather. It's a long exposure. We have them breathe normally. It's going to blur out those lung markers and just make that sternum really pop. So the best way to do it is a breathing technique, but if we don't want to use a breathing technique, just suspend at the end of expiration. That's the other way we can do it. It has to be expiration, by the way. Yes.
Was that the orthostatic breathing thing that we
That's the
talked
same as orthostatic
Okay.
breathing, correct. Correct.
So this is suspended respiration, expiration.
So you have two methods. The best is a breathing technique,
Which is.
but if you do not use a breathing technique, you're just gonna have them stop breathing at expiration and take your x-ray. Blow the air out, hold it out.
That's the one with X-ray.
Yes, we're not gonna
Cause I
do,
get confused with those on the test and stuff.
that's why I said pay close attention because you're gonna change with every single position in this chapter. Just be careful. Suspend at the end of expiration. The breathing technique is considered the optimal respiration technique to blur out the lungs. Those really pretty sternum x-rays you see in your book, they're pretty because they use a breathing technique. When you don't, it's gonna look really ugly. It's gonna be hard to see. You're not gonna get that fine detail. So breathing technique is, so what Jay said with orthostatic breathing, we're telling the patient just breathe normally, in and out. I'm saying a manual technique, which is my KP, my MA, and my seconds. That's what we call breathing technique. We're gonna take the exposure as a breathe, will be a long exposure.
So-
Breathe as a breathing. But if I don't wanna do that, I can do what I usually do, where I just set a regular technique, or AEC, just tell them to stop breathing at expiration. 2 ways of doing it. The best is the first one that I have highlighted. Second one would be less optimal.
I've never done it.
Most of your texts aren't gonna do that because it's kind of complicated. You have to do some math in your head to do it right.
What were the other exams we did orthostatic breathing for? Like X-ray? Which one?
Which one did you do
Yeah,
that for?
I feel like there's only 1 or 2 other
Which one
ones.
was that?
The transthoracic.
Yeah, transfer.
Yeah, there you go.
Okay.
That was a transthoracic, and I believe also Semi did orthostatic for like soft tissue necks, when I get them as a breathing unit.
Have we done that?
There's different.
Soft
different
tissue
areas.
necks?
Yeah, that was
Scapular,
some person
was it scapular?
with the transsthoracic something to
Oh, right.
Make sure on that one. I'm not sure on scapular.
I just saw it in LBG.
Okay, guys, center ray, perpendicular, we're not anywhere there too. It's straight at the patient. That's also near the elevated side. Be careful, most people make the mistake on the REO of putting that crosshair directly on the patient's spine. Remember, when you do an oblique, you always slightly adjust your centering towards the elevated side, or the upside as we say. So in an REO, like this, which direction am I gonna move my centering? Towards the left, because the left is the elevated side. Otherwise, my centering is going to be off. So it doesn't compensate for the obliquity of the patient. We go towards the elevated side on an oblique.
That's gonna be a pose for everyone.
Every oblique, you always go towards the elevated side.
Whenever they're oblique, the light doesn't have to be all the way to the other side, right? Because it's obviously on the ribs that are outside.
Into my ribs.
Or what do we start? Sorry, just slightly.
Just slightly. It's about an inch. So like, depending on how thick your fingers are, 1 or 2 fingers toward the upside. Alright, and if you do that breathing technique, once again, you're getting a pretty picture like this. That's a pretty sternum x-ray. If you do the expiration method, it's going to be blurry and not as pretty. But when we're talking about evaluation criteria, what are we looking for? Of course, a slightly, keyword is slightly, oblique projection of the sternum, and obliterated, I like that word, obliterated pulmonary markings with breathing technique. Once again, because that's the superior method of getting an x-ray. Can't say that word. Obliterated pulmonary markings would be the blurred out lungs. That's what that's referring to. Obliterate is such a strong word. Obliterate. Of course, evidence of proper collimation. Do not leave that collimation open in a 10x12. This is such a finicky bone. Tight collimation is gonna give you a better image across the board on this. We want to also see the entire sternum from the jugular notch to the tip of the xiphoid, which is why I have the patients do this, to make sure you get the top to the bottom. If you eyeball it, you risk cutting the top and the bottom off. And then, big one here, guys, that's a test question. We do want the sternum projected over the heart, but free of superposition from the T-spine. So we oblique it to move it away from the T-spine, but also project it over the heart shadow, so it'll help us see it a little easier, which is why we only do REO. If we did an LEO, it wouldn't be over the heart. We wouldn't see it as well. So the REO puts the sternum over the heart shadow and allows us to visualize it better. Boy, is that not a good test question. Do y'all feel that one? Can you feel it? I guess I'm the only one that can feel it.
Sorry.
We're gonna get ready some coffee. You okay?
I had my coffee this morning already. I don't know.
Hey, yeah, it's all right. We all have our days. It's okay. What was you asking? I'm sorry. I already forgot your question, Sam.
What did you say? You said something about step test question.
I said that's a good test question there. Why do we do the REO specifically? Project the sternum over the heart to better visualize it. Or in reverse, how else can I ask that question? Why do we not do the LEO? What would you say? It would not be projected over the heart. We would not see it as well. Always think of other ways you can ask the same question.
Not the T-spine.
Correct. We move it away from the T-spine, but put it over the heart. Man, that is a test question if I ever saw one. Don't be rude. Would it be rude if I didn't say it?
Maybe it's like something really hard and I'm not able to do it.
I'm just gonna put this thing that's on the test. You offended me.
Like
Not
for
really.
her version of the test.
Not really.
Wait, you want it projected over the heart?
Yes, it helps us visualize it better.
Wait, why would you want that?
Why would you want that? The sternum's very hard to see. Put it over the heart allows us to see the outline a bit better because of the different densities.
Oh, okay.
Is that picture over the heart?
Yes, it is. All right, a little bit more evaluation criteria, guys. Once again, minimum rotation of that sternum and thorax. How do we know we have the minimum rotation? The sternum will be free of superposition from that T-spine, vertebral column. We want minimally oblique vertebrae. That is going to help us not have the excessive rotation. If we put that patient in a 45-degree oblique, it's actually going to miss the heart completely. We won't see it as well. That's why we need that slight oblique. We want the lateral portion of the manubrium, which what is the manubrium again?
The
top
top
portion
Top of the sternum. The lateral portion of the manubrium means the side towards the side of the body. This side, if you don't know what I'm talking about, lateral side of the manubrium. And SC joint free of superpositions of fiber vertebrae. That once again tells us we're in that 15 to 20 degree oblique. And blurred pulmonary markings, which we achieve with a breathing technique. Yes, Shane?
Sir, clavicular notch and the SC joint are the same.
Yes, sternoclavicular is the entire name. SC is the shortened.
6 months,
So
sorry.
sternoclavicular is the whole name. SC is the shortened name.
No, what I meant was that when we do the clavicular notch, is that the same?
The
can
clavicular
we-
notch is just where the clavicle fits into the sternum.
That's not the SC.
That's not the SC joint. Yes, Jay?
How do we put the marker in this image?
So that's a tough one. This one is tough. So what I do, once again, this is what I personally do because I use very tight collimation. Have y'all heard the stories of my terrible collimation?
No.
I mean my super tight collimation?
You have to read it.
Terrible.
Which is why y'all should be thankful I don't do your capstone. Just believe this don't need
Oh,
this.
sure.
I am crazy about tight collimation.
You killed everyone.
I've failed a lot of people, yes. Not for just collimation, for other stuff too, but I grade really hard on capstone. Anyway, what I do is, I find my centering on the sternum and my collimation. Now, before I put them in the REO, what do you think I'm gonna do? I'm
Step
gonna move
to
them
the
away and put my marker in the light field, like in the top corner. That way I know it's gonna be on the picture. So I don't wanna try to guess, like I don't want the patient up against the board and try to squeeze it in there, because what might happen, my marker might end up in the manubrium if I do that. So I'll make sure it's in that little corner at the top, just to be sure. That's what I personally do.
Would you take it to the patient?
No, why is that a bad idea?
What?
Tape it to the patient.
The
Well, I would-
patient will go away with the
lose your
marker.
Why is that a bad idea?
Patient might walk away with the marker.
Well, you might put it on the
Aside
actual
from,
anatomy.
no, what's like from a PRE or a QC, QA standpoint, why would that be a bad idea to put the marker on the patient for sternum?
Oh, it,
Infection.
What's gonna happen? It's gonna magnify it.
yeah.
And then once again, if it's magnified, it might get in that manubrium. So putting it on the patient is gonna really magnify that marker.
Okay.
Yeah. I know you see techs do that all the time, but that's usually a bad idea to put your markers on the patients.
Like the top right.
They don't-
Girl, I know.
Unfortunately.
Do you use the markers for? Me. I'm like,
All right, guys, y'all are depressing me. Go take a break. Go get y'all some coffee. Y'all are looking kind of rough.
Back at
Go
this
ahead,
time?
go ahead and take.
Hey, if it's
Hey,
not-
you look so good. Like you look very energetic.
Oh, I feel great.
Sorry.
We look
Take
good.
15 minutes, guys. Come back at 9:10. 9:10.
Put the marker on the top right.
That's what I do. Top right. So, yeah. And generally, in oblique, you want to mark the side down. That'll be the right side that's down. Yeah. So use the right marker. Preferably.
How do we mark it when the patient is not standing?
If they're not, like if they're on the, like laying on the table.
No, you said we will remove the patient before the patient goes on the IR, you should put the marker. So then But how do you mark it for the patient is there? You know where to mark for the sternum, sir?
Like if they're standing up,